औज़ुबिल्लाहि मिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम नहमदुहु व नसल्ली अला रसूलिहिल करीम अम्मा बाद. Thank you very much again for joining me today for the fourth of the series of six presentation in pediatric dermatology in ER. Those of my colleagues who have joined us for the first time today, I am Dr. Amjad Khan, consultant pediatric dermatologist at Shifa International Hospitals Islamabad. I have the privilege of being Pakistan's first Western-trained pediatric dermatologist, and I worked in London for nearly 2 decades. I was trained at Great Ormond Street Children's Hospital, which I will share in a few of the slides today as well, because one of the topics pertains to a very specific skin disorder for which Great Ormond Street Children's Hospital is center of excellence in the world. Now, with regards to the disclaimer today, obviously this is a CME activity which myself, our educational CME team here and my hospital or organization has no financial interests to declare. This is a pure educational event. Now, the topics for today, I have to apologize in the start because this presentation is going to be slightly longer than the other ones. It has few case scenarios from American Association of Dermatology. So the topic involves four of the main presentations. Bearing in mind, we are talking about presentation in ER. So we'll be more relevant to that, especially in EB, Epidermolysis Bellows, acute management and looking outside the box. So with regards to Hemengioma, let's start. This is the international classification for vascular anomalies. You can see I've marked that vascular tumors and vascular malformations. We'll talk about vascular malformations in one of the scenarios as well, which is arteriovenous malformation later, while this is the hemangiomas fall into vascular tumors, which are and then benign rather than malignant. So you can see the benign part have been expanded into these. First of them is infantile hemengioma or hemengioma of infancy, while others are rapidly involuting, non-involuting, and partially involuting hemangiomas. And then obviously other types, especially pyogenic granuloma we see quite often, and sometimes tufted angioma. Now, with regards to the infantile hemangioma themselves, there are different varieties and different types of them. I will go a bit in detail in the hemangiomas because most of us will come across them, pediatrics or dermatology, so the patterns are either focal, so they are single, solitary, multifocal, they have multiple lobules, segmental. We'll talk about that, very important actually, because they have intracerebral malformations associated with them, and then indeterminate, which you can't put in any of these categories. Then different types. We'll again, we have got photographic comparison of these in few slides. Superficial, only on the skin, a deeper, mixed, which has both components, and then others. And then associations. So face syndrome, we will talk about that later. Lumbar, sacral, and pelvic or pelvis syndrome, they are slightly rare, but please do consider them in your differentials when you're looking at vascular birthmarks, including hemangiomas. So these are the sort of more common ones. So you see the superficial one, which is cherry red on the right left upper corner. Then the one which is on the child's arm is mixed one. So it has sort of superficial component which has faded over time and then has got an ectoderma or lax skin. And then you can see one on the under the chin as well, which has deeper component, but it's not very visible here. I will show a few other photographs as well. So what are hemangiomas? When a child presents to you with hemangioma, the families will ask, especially I'll put few words across in Urdu as well. Dr. Sahab, ye kya cheez hai? Kyun hai? And the first thing, unfortunately, our population asks, kya ye allergy hai? यहाँ हर चीज एलर्जी से रिलेट कर देते हैं. I don't know why. Then obviously, please do take your time, step back, talk to them, educate them on the first consultation, so they don't have false information, they don't have false hopes, and they know what it is and how to treat it and what are the options. Now, infantile hemangioma is glucose transporter 1 positive or GLUT1 positive. And that's the difference, because other type of hemangiomas like rich, niche, and pitch, which we talked about, and I'll show you in the next slide as well, they're GLUT1 negative. And that again gives us an idea, because there is a hypothesis that hemangiomas are placental tissue derivatives, because placental tissue is GLUT1 positive, and when the placenta is under stress, it showers the cells and it gets connected to or sticks to the child or the baby and grows. And probably that's the reason, if you see, they are not present at birth, they are noticed in the first few weeks of life, then for the first 6 to 12 months they grow, and then they stabilize and then involute by up to 90% in 9 years. So this is sort of a pattern, standard pattern for the hemangiomas. So you can see rapidly involuting, congenital hemangioma, partially involuting, and non-involuting. And for non-involuting, we did trial vascular Pdl laser, and there is a presentation, there is a paper, research paper, which my colleagues and myself, we have written in Journal of Journal of Dermatology in Pakistan. So please, JPAD, so please do refer to them, to that, if anyone of you interested. Now, different types. Again, superficial hemangioma, left top. Then there is a mixed variety on the temple of the child. Then you can see the sort of a plaque type hemangioma, and different presentations on different parts of the body. What are the treatment options? So nowadays, the first line is beta blockers. We could use vincristine if needed, and especially in those which has Cassabat-Maritz phenomena. While pulse trial laser is for ulcerated or complicated hemangiomas, surgery if everything else fails, and then steroid, interferon, and imicamab has been used as well. But these were previously used more often. Now they're less and less used because beta blockers are very effective. So what are hemangiomas? So these are obviously very common, roughly 1 to 2% of newborns, and female infants have more incidence of that, of the hemangiomas, and preterm babies. Now, with regards to the superficial and the deep component, you can very clearly see what is a superficial sort of reddish hue, cherry red hue, and on the other side, that's the deep one. One thing you might have noticed across all these photographs, they are on the face, limbs, and mostly in the nappy areas. Trunk, very less. They do, but very less. And as I've mentioned previously, they have proliferative phase when they grow, then plateau, and then involute. And you can see 60% of them happens on the face, head, and neck. Now, previously, we used to have corticosteroids, which we were using as standard or traditional mainstay, and oral, intralesional, or topical. And several injections were needed. Again, with regards to the closer to the eyes, it was very difficult, and only experienced physicians could use. We'll talk about the beta blockers a bit in detail according to our Great Ormond Street Children's Hospital protocol, which has been adopted by the British Association of Pediatric Dermatology as well. Now, coming to pediatric vascular anomalies, we have, like we have discussed, vascular tumors like the hemangiomas or vascular malformations. And the difference, we have again shown you the same sort of table and this in the slide in the start. So this is port wine stain. We'll talk about it, and we will do some AAD, American Association of Dermatology based clinical scenarios in next few slides, where you will see the progression. But you can see port wine stain, how beautifully it responds to the PDL or pulsatile laser. Inshallah, I'm hoping to offer this treatment of Pdl vascular laser once I've got the laser machine sorted here at Shifa International, and that will be purpose run, first of its kind in Pakistan. Birthmark, vascular birthmark clinic here, inshallah, soon. Now, history. So I might have explained at some point in the past that pediatricians are very pertinent to the focus and the fine details, and they are more sort of nature loving. So their hobbies include gardening and sort of physical fitness. On the other side, dermatologists are very much into history and technology. So if you have the combination of both, like I am, so you get the best of both sides. So let's talk about a few points in history. Interesting enough, there was a misconception even in Wales up as early as 1980. Quarter of the women were thinking that port wine stain is because of maternal consumption of strawberries. So it is interesting to see how late our ideas have followed the scientific outcomes and scientific research. Now, first case. Sorry, let's talk about the case. You see a 4-week-old infant with this superficial hemengioma on the arm. It is growing now. When should the parents expect the hemengioma to grow the most rapidly? Now, if you have a piece of paper next to you, you can sort of answer the questions yourself and then compare it with the answers here. So this is the sort of options available when you counsel the family. I will hang on to this slide for a few seconds so you can look at all the options and choose which one is the appropriate. So we are talking about the rapid growth phase. So it's actually the option B, 5 to 7 weeks of age. And because infantile hemangiomas proliferate in the first 2 to 3 months, then plateau phase, and then usually starts to involute. Now, you can see superficial, deep, and mixed hemangiomas. We have repeatedly, I've shown these photographs just so that it sinks down in our mind with regards to the hemangioma. And now they can happen anywhere on the body, but if they are in specific areas, then we need to worry about them, especially the segmental hemangiomas. Like this. So one is focal, which is a standard hemangioma. The other one is segmental, in a patch of the skin, in the segment of the skin. Why we need to worry about it? Well, we will talk about it when we discuss face syndrome. So in general, hemangiomas do have some complications, and that is more important when they present to you, most of us, when we are first line, front line, and in ER, even in our clinics as well. So ulceration. So parents might not come to you if they have the focal hemangioma like this, because they will say, "ठीक है भाई, पैदाइशी है या हो गया है, और वक्त के साथ शायद ठीक हो जाए," and people give them false reassurance. But what happens when it starts getting ulcerated? Or if there is any airway, like if breathing problems. So with hemangiomas, we do worry. Now let me obviously slow down here and give you a bit of idea. If it is close to the eyes, we worry about glaucoma, and we worry about eye involvement. If it's in the midline, especially on around the mouth or in the neck area, we worry about our upper respiratory tract involvement, and then needs to be seen by the ENT doctors, because airway involvement, as you can understand, you see the child which is 4 weeks, 6 weeks have got this hemangioma. Remember, in the first 2 to 3 months, it does grow very rapidly. So if it's inside involving in the upper respiratory tract and it grows suddenly, it will result in airway compromise. So do consider these things in the back of your mind. And then obviously aesthetic complications. Now, let's talk about the other case. Well, it's the same case, but other points relevant to the hemangioma. You can see in this 4-week-old infant with a large hemangioma on the arm, what complications are you most concerned about? Now look at the photograph. What do you see? This is a erythematous vascular lesion, regardless whether it's hemengioma or not. But if you see center of the lesion, it is more paler as compared to the outside. Two things can happen. Either the blood supply is getting compromised, or the second thing is like the lesion is outgrowing its blood supply, or the second thing is it is an involution. So look at the history provided, 4-week-old. So do you think in any hemangioma will involute when it's in 4 weeks or 6 weeks or 8 weeks age? Unlikely. Mostly in the first 3 months, it has proliferative phase and then plateau and then comes down. So it is still in proliferative phase. Hence, if it is proliferative phase and it's paler in the center, so it might be outgrowing, the lesion might be outgrowing the blood supply, which means it will get infarcted. The skin will get infarcted. The skin might slough off and might result in ulceration. So I've given you the answer. The wide discoloration and the location marks makes ulceration very possible in this hemangioma. But I will let you read the other options because it has few basic points and information relevant to the hemangioma. This presentation, just for those who have joined us for the first time, all of my presentations will be available at Shifa International Hospitals Facebook, YouTube channel, as well as my website, dramjadkhan.com, and my Facebook channel as well. Now, ulceration is the most common complication. Nearly 10% of the patients can present with ulceration, and most commonly on the mucosal sites. Early white discoloration, which we have just talked about, that reflects the infarction or outgrowing the blood supply. Treatment now: gentle cleansing, soaking, removal of crust. But remember, ulceration is painful. Please do consider pain relief in a child. If the normal painkillers don't help, you might have to move up to or step up to morphine or any sort of stronger opioid-based analgesia. Now, liberal emollients, barriers, pain control, but please do consider infection. So pain control and infection, and then obviously we have to make the child comfortable. Rule out infection, and then obviously how to manage this ulceration itself, which is removal of crust, cleansing, soaking, moisturizer, and then now with regards to ulceration, because it is one of the indications where if hemangioma gets ulcerated, then we use Pdl Vascular Laser because it quickly calms down the pain in the ulcerated hemangioma. Oral propranolol is another indication, and sometimes topical metronidazole cream. Now, visual impairment. So if it's around the periorbital area, do think about the size. So it can it can have effects on the mechanical, so proptosis, amblyopia. So because remember, a child's vision develops in the first few years of life. So in first year is very important. So amblyopia, or visual access correction if there is because of that compensatory eye deviation, and then obviously glaucoma or other problems. So think about outside the box. So we are not in ER. Let's say somebody presents like this to you, sorry, or as first line, you don't have to deal with only the hemangioma which is in front of you. But if you just let them go, bearing in mind you might not be in the main city hospital, you might be in the slightly periphery, you might be in a very periphery, then remember, you are the only doctor they have seen. They might not have an idea what it is, what are the complications, what will happen to the child. आपने उस वक्त एक्ट नहीं किया, बच्चे को एम्ब्लायोपिया हो जाएगा, सारी जिंदगी के लिए आंख जो विजन है खराब हो जाएगी. तो not only ethically but religiously, ये तो आपकी सारी जिंदगी का आपके ऊपर एक बार है, आपने बच्चे को हेल्प नहीं की. So please be considerate about it. Do consider and think outside the box. Very easy to treat. So there is no reason why we cannot treat hemangiomas. Airway, as we have discussed earlier as well, laryngeal involvement, and it can be life-threatening emergency. So if a child with midline hemangioma, especially on the head and neck, and has got stridor, hoarseness, Do ask about. If you see midline, just ask if आवाज ठीक है, सांस तो नहीं खराब होती, खांसी तो नहीं करता, कुछ और इश्यू तो नहीं है, रात को यानी बच्चा खुर आवाजें कोई और या खुराटे तो नहीं लेता, छोटे बच्चे नहीं लेते इतना. So then obviously think about that, think about outside the box. Systemic therapy, oral propranolol, oral steroids, or both. I usually prefer a combination here because we need quick action. And then emergent referral to the emergency. I think I have written down a case report as well that was from Great Ormond Street. So if somebody wants to look at that, what was the sort of treatment we used? It was 2 milligram per kilogram of oral prednisolone along with oral propranolol, but higher dose, and the child was in intensive care. That I ended up writing it down. It was Friday evening when I saw that child. I spoke to my consultant, and very kind at that time. Very quick action from everyone in the team. And by Monday when I came, everything was fantastic. Now, multifocal. Always think about other organ involvement if you have multiple hemangiomas. More than 5, do worry. Again, there is a bit of academic discrepancy between Americans and Britishers here, or Europeans here. Less than 5, more than 5, or more than 10. But if there is a general no consensus between the two groups. So even more than 5, think about options. Like is it systemic involvement? Hepatic hemangiomas, they can be asymptomatic, but they have other they can have sometimes they can have higher output cardiac failure associated with that. And so abdominal ultrasound is recommended. We'll talk about the protocol soon. It's in a few slides. Now, aesthetic component. Look, this child's face is involved. Now, if the hemangioma is significant, bigger size, hemangiomas will resolve at some point. 90% of them do, 10% don't. But if we don't jump up early, अगर हम जल्दी input नहीं देंगे, ये skin इतनी lax हो जाएगी, इतनी loose हो जाएगी कि यहाँ anatoderma या lax skin हो जाएगी. So even the child grows into it, cosmetically disfigurement होगी. फिर cosmetic surgery, plastic surgery हर कोई afford नहीं कर सकेगा, और issues बनेंगे. तो propranolol या beta blockers are reasonably cheaper. So why can't we treat it early before them getting so bigger and monstrous that it affects the child for the rest of their life? Think about abuse in school. Other kids will be so sometimes can be naughty. They can pinpoint to the child, I don't want to be your friend because you don't look nice, and things like that. So think about mental well-being of the child and the family as well. It's not only the child, it's the whole family that gets affected with it. So please do consider these things and think outside the box. It's not that you are the first line responder and the doctor, or an ER or in your clinic, and you only have to deal because you're a dermatologist or you're a pediatrician, you only have to deal there and then. Think outside the box. Think about the child as it's one of your child in your family somewhere, and you are trying to help them, not only there, then and there, but in the long term. Now this next case, this infant has a large vascular plaque on the right face and scalp. You make a diagnosis of segmental hemengioma. Here we go, segmental infantile hemengioma. Very important. We'll now talk about the segmental part of it. What association syndrome should you consider in the setting of this type of birthmark? So we have talked about faces or face syndrome. So it's part and parcel here. You can see, and it's a segmental type. Sturge-Weber is Port Weinstein. That's a total different pathophysiology. So face syndrome, posterior fossa abnormalities, Dandy-Walker malformation, hemengioma on the face, more than 5 centimeter and a large segmental hemengioma. Aortic, so echo, MR, echo on the top of treating the hemengioma, and eye abnormalities. So what workup is recommended? I've already told you. So it will be all of above. MRI, MRA, if you are worried about the vasculature, and we do sometimes, unfortunately, because there is abnormal connection or stenosis, and we give them oral propranolol, and you can harm them actually. So here you go, having more than one region of the face involved. It's depending on the size, location, and distribution of the hemangioma. And it's not that everyone will have these associations. Roughly 1/3 have. And that's another thing for face syndrome. segmental large hemengioma on the head and neck, has multiple other anomalies. This is obviously a taster for you all, my colleagues. So you can go and read about things in detail if you want to. We are obviously one short of time because we have to cover so many things. But the other thing is, this is in the setting of ER. So if you pick up this, refer to cardiology, dermatology, involved cardiology, ophthalmology. So you have to. This is just to give you a flavor that if you see a patient with segmental hemangioma, you just can't just let them go outside the door, say thank you very much, it will be sorted or settled and nothing else, give painkiller and beta blockers. And you have to first look outside the box, think about the underlying pathophysiology, refer or engage the relevant specialties, and then give them whole information, book them in for other people, and then let them go. So recommended workup for face syndrome is echo, MRI, MRA, ophthalmology evaluation, and PhD, obviously, because it's a multidisciplinary team. Other complex sort of lumbar or sacral syndromes, they have other anatomical abnormalities. So again, another thing, if it's very early on, you are a pediatrician or pediatric junior doctor, you are doing the baby check, you have noticed this, look at the whole part of it. So anal abnormalities, anogenital abnormalities, imperforate anus, spine. So all these things you have to consider. So this gives you a sort of a stimulus to look outside the box. And with regards to the question and answer, we will hopefully, inshallah, do it at the end of the session, because we have a long session today. We might be overrunning for 10-15 minutes for those of you who want to reschedule their timings or their commitments. So infantile hemangiomas, topical therapies, beta blockers, steroids, imiquimod. To my knowledge, unfortunately, imiquimod is not available in Pakistan. Please correct me if I'm wrong. Write down in the text box the name it's available in. So obviously I can get myself updated. I've only been in Pakistan for nearly 2 months, so it's a bit of restricted information for me with regards to this. Supply line chain issues are very common here. Now, with regards to local treatment, interlesional steroids, pulsatile laser for ulceration or residual lesions, oral systemic therapy, oral propranolol, corticosteroids, immunosuppressives. Now, bearing in mind oral propranolol, but topical timolol. So if it's 2 centimeter or less than 2 centimeter and solitary, single focal lesion, you can use topical timolol as well. Here we go, the topical timolol, and you can use it different options. It's 0.5%. Sorry, it's not 0.05. It's 0.5%. 2 drops twice a day or 2 drops 3 times a day. Different people will have different engagements with this sort of case reports and case series. Propranolol, obviously, it's very well known and noticed and used. Some common side effects: hypoglycemia, hypotension, and bradycardia. Sleep disturbance, very common, because it crosses blood-brain barrier. That led to other colleagues across the globe finding other like atenolol, nadolol, and other beta blockers which have less penetration through blood-brain barrier. But still, as it stands, propranolol is the best, along with timolol topically. Now, some guideline things with regards to propranolol. Those of you who are comfortable in using those in young children, you can see initiation in infants for more than 8 weeks corrected age. ECG, EKG or ECG is advisable, not essential, depending on if the child is term, no other cardiovascular history, normal examination, normal blood pressure. And some centers will do mandatory ECG and echo. So it's up to you. What's your local arrangement? What are you comfortable with? Steroids were used prior to 2008, but what happened in 2007 in France, one of our colleagues, Dr. Christine Labraise, and her colleagues, they had a child who was in intensive care for steroid-induced cardiomyopathy, and but was given propranolol because of cardiomyopathy. They were consulted because of the hemangioma, but she was very observant, as most of us are scientists as well, because of the science reading. What happened, she noticed that over the days she was reviewing this child, the hemangioma got shrunk very rapidly. So then she looked at the drug chart and thought that the drug that may be affecting, may have an effect on the proliferating infantile hemangioma was propranolol. And then obviously the ball started rolling. Now, this is Great Ormond Street Children's Hospital. My colleagues in London doing fantastic work. If you are new to the center's information, then please, I will advise you to look at the publications. They do extensive research. Dr. Leah Solomon Kustik, Dr. Martinez, the late Professor John Harper. Unfortunately, he passed away just before Ramadan. Dr. Samira Sayed, fantastic teacher, and Dr. Mary Glover, my supervisor. So this team, our team did presented this and then have published it. This was adopted by the British Association of Pediatric Dermatology. You can see there are so many complications, including ulceration, vision compromise, feeding problems, airway obstruction because of hemengioma, and hence we have to worry about whether it's ulcerating where it is. Like in this child, every time she passes urine, it will irritate. The skin will get irritated. If it becomes ulcerated, it will get easily infected. It will sting her. So many complications. So jump early because there is a treatment available now. Again, here, like we talked about ptosis, amblyopia, visual access correction. This child's vision needs us to jump in early, treat it so that the vision develops normally. Now, Great Ormond Street Protocol, I'm just sharing with you. Please, it's available free on online through Google Scholar or British Journal of Dermatology. And you can see the mean age was around 4 months of starting, median age, and then median age at end of treatment was 16 months. So it's roughly a year's treatment, roughly. Obviously, every child is different. And then some common side effects: wheezing, worsening of ulceration, sleep disturbance, and diarrhea. And then, but again, only in 15%. And then other patients had excellent, 96% had excellent response. Then again, only 8% had regrowth of the hemengioma, where the propranolol was restarted for a few months and then slowly reduced. And these were the common side effects noticed, as we have already presented in the text form. And you can see before starting propranolol, full examination, heart rate, blood pressure, oxygen saturation, written information for the family. That's what I'm hoping that in next few months I will try writing the basic information leaflets in Urdu for Pakistani parents. In English, it's available anyway. So I co-authored 7 of the basic information leaflets for American Association of Pediatric Dermatology, including the hemengioma, eczema, and psoriasis and other things, warts, etc. But in Pakistan, we don't have that written in Urdu. So I'm hoping that we'll be able to translate some of that work in Urdu for our patients locally here. Now, clinical photograph. Nowadays, everyone has got a mobile phone with a smart camera. Encourage the family to take a photograph, but and tell them not to delete it. Some of them, unfortunately, do. And then ECG and echo, but ECG and echo in selected patients, not everyone. What selected patients? We'll talk about ECG if the heart rate is below normal for the age, if there is history of arrhythmia, if there is arrhythmia on examination, if there is family history of congenital heart disease or maternal history of connective tissue disease, then ECG. ECG and echo again if there is family history of cardiovascular disease, or if you suspect it's a segmental hemengioma for part of Faces syndrome, then again, think outside the box. How do we start? 1 milligram per kilogram per kg in 3 equal doses. In week 1, we will call them in week 2. Examine them again, do the basics, and then step it up to the week 2 dose, which is 2 milligram. And here we will stay. Now, this is again British or European practice. Some people will deviate. Americans go slightly higher. They go to up to 3, sometimes even slightly beyond 3. The more the dose, the more the side effect. With Faces syndrome, start cautiously. Be slow. There is no need to jump up quickly and give them higher doses to give them side effects. Give small doses until MRA excludes arterial malformation of head and neck. If MRA is not available in your center and you suspect segmental hemengioma, please don't start propranolol. Refer them to the bigger center, tertiary hospital, and write down clearly in your referral letter or discharge summary that MRA is needed because of the worry about Face syndrome. Now again on heart rate, how often to do the observation and monitoring, less than 5.5 and more than 3.5, how long we can, it's a day case. You don't need to keep them in-house. It's a day case. They will come in, they will stay for 2 hours or 4 hours. Blood tests we usually don't. But as if you remember, we have talked about multiple hemangiomas. So if more than 5 or more than 10, more than 5, we usually start this. So liver hemangioma we are worried about, so we do thyroid function. It's consumptive hypothyroidism and liver hemangiomas if there is, and then parotid hemangiomas. So if it's on the neck area, sort of this angle of jaw. And face syndrome, again segmental, and the liver function test will be part of the liver hemangioma screen, full blood count if it's a bleeding hemangioma to rule out clotting, abdominal ultrasound as we've discussed. Here we say more than 10. Now we usually like to be more cautious and do it more than 5. MRI brain, MRI spine, again with relevant syndromes. ENT team, as we have discussed, hemangioma on the midline, suspected airway hemangioma, ophthalmology if it's around periocular. Review every month. Now we have got technology in-house. Again, the work pattern or the way it works here in Pakistan is much different. Less of a government sponsored healthcare, more of a sort of personal one. So you can give them the option to send you the WhatsApp photographs or remote consultation evenly. So they don't need to come in for the consultation once it's stabilized. Increment of the dose, if the child is growing very quickly, you need to have the weight, so you can, the family can weigh them their local clinics and tell you that when they are having the consultation. Now extras, obviously, like more than 10 cutaneous lesions, I would probably say now 5 rather than 10. And with regards to patients should be informed not to use lignocaine along with propranolol, because teething gels have lignocaine in them, and salbutamol, be careful if you are using. Then other thing is salbutamol is because there is an alternative medication, ipratropium, you can use in case of bronchospasm if need to be. And yes, because it can cause hypoglycemia, and kids are very young, so they won't be able to tell us. So strict feeding regimen. So feed regularly to avoid prolonged fasting. And propranolol should be discontinued during intercurrent illnesses, especially in the setting of restricted oral intake. Hemangioma, you can see plaque hemangioma, middle one is ulcerated and one is standard superficial one. Ulcerated hemangioma, think about the one on the buttock, it will be significantly painful. You need to jump in and start treatment early. You can see the response after propranolol, fantastic response. Other thing is Pdl Vascular Laser, which hopefully, inshallah, we are planning to start this vascular laser service for birthmarks, hemangiomas, and any vascular malformation here at Shifa International Hospitals Islamabad. You can see the outcome. If you jump in early, you can see the little girl at the lower end, and you can see the the child on the up. It still has a bit of anetoderma, and you can make it out, but in the young girl on the lower screen, on the lower photograph, it's not noticeable at all. So please jump early, go in early with the treatment. Hemengiol, this is the licensed product. It's available in states, hugely expensive, but locally you can compound yourself. If you have compounding pharmacy, ask them and they will arrange the propranolol solution. Here in Pakistan, remember, you have to shake it before giving it to the child, because the sediments settle down. So that's another practical tip. Now, one of my colleagues, when I finished my fellowship, she started it, Caroline Mahon. She's now in Australasia, and so she presented this and did the research letter. Oral propranolol, because it crosses blood-brain barrier, can have transient gross motor delay, so a bit lower and thinking for long term for a child. So see, everyone is thinking for the long term for a child, that are we doing any harm to the child? So if you are worried about propranolol, if the child is already other issues, then other medicines are available. So just always think outside the box, and do keep an eye out, watch out for these things as well. These are the references. Let's summarizing this infantile hemangioma, possible complications and suggested workup. I think we are quite running late, so I will go a bit fast forward. We've got quite a few slides left. We have just come into the middle of the presentation, so you can see I have to speed up now. So case 3, this is an 8-year-old boy presented for evaluation of large 8-day-old, large pink mark on the forehead. Here we go. So this is not hemengioma. Faint, dull pink, well demarcated. What would you do? Reassurance and education. Why? Because this is nevus simplex, Salmon patch, faint, transient capillary malformation, nothing to worry about. And usually there are so many names. So stroke bite, angel kiss, there are so many names for this as well. Usually fade in the first few years of life. Case 4, a 6-month-old baby with a lesion on her face, present since birth. So was present at birth. Here you go. How would you describe this lesion? Dull red patch on the face involving the upper eyelid, forehead, temple, and scalp. What do you think it is? It's a capillary malformation, but cutaneous. So it's port wine stain. Remember, this is the child patient I showed you, had a laser, Pdl Vascular Laser as well. So capillary malformation, these are present at birth. They can have these lumps inside the vasculature. This is obviously a young person, I think around late teens. And do we need to worry about it? Yes, because it's involving the face area, so eye area. The port wine stain close to the eye. Anything close to the eye, think about eye. Sturge-Weber syndrome. So distribution of the first branch of the trigeminal nerve. Now, do remember, now this has slightly changed. Professor Veronica Kinsler, again at Great Ormond Street Children's Hospital, her team presented. Previously, we used to think it was the nerve supply of trigeminal nerve, but now it is thought to be the embryonic vascular supply. So I'll show you that as well in a minute. So Sturge-Weber can involve intracerebral and then seizures, epilepsy, glaucoma. So think outside the box. Management, depending from dermatological perspective, Pdl Vascular Laser, we can do fantastically outcome. We work in a MDT multidisciplinary team with the pediatric neurologist. And here you go. You can see the laser has done fantastically. This birthmark has nearly disappeared. Now, this is the new classification. I've given you the reference here, so you can go and look out for it. It's the new vascular classification of port wine stains by Professor Kinsler and team. And you can see this is blood supply rather than the nervous supply. So up is the left top is the blood supply, which we at the moment used to think. Now the new classification says, which is at the bottom right, this is the blood supply, and anything in the blue area, which is the facial play code, it needs imaging and have more involvement intracerebral. What will happen if we worry about PWS? If there is MRI is normal and neurology, so examination and MRI both are normal, nothing to worry about, only follow up. If abnormal neurology, refer to pediatric neurologist. If MRI is abnormal, refer to neurologist. And then obviously the protocols are there. You can read about it from the reference provided. So when you are on the front line, see a child with this, examine the child, consider MRI if the child is seeing you for the first time, or refer according to your local availability to pediatric dermatologist or pediatric neurologist. Case 5, 3-month-old presented with this lesion. The parents are concerned that her arm has consistent, permanent mottling. One is temporary, one is permanent. This is very rare, but I've seen at least once in Pakistan, and reasonably common because of our population. And this is mottled reticulated pattern, and this is cutis marmorata telangiectasia congenita. Again, Pdl Vascular Laser can deal with it. It calms down, settles down slightly with the age as well. But so 2 options: others wait and watch, or you can do the vascular laser. And sometimes that part of the leg or limb can get extra blood supply, so can be slightly bigger than the other part. Associated with other syndromes. So examine the child completely. Trisomy 21, 18, Cornelia de Lange. So there are so many other etiology. So always examine the child completely. Now, case 6, I'm going slightly faster because we have to cover other topics and subjects as well. 12-year-old boy who presents with bleeding hemengioma. Now, this gives us the idea. 12-year-old, is hemengioma common in that age? No, this is quite atypical age. Never had any vascular lesion in the last 10, 12 years. Just came out without any prodrome, without any issues. And on the left thumb, so more of on exposed part of the body. Trauma, has the trauma caused that? So think outside the box. I'm sure most of us would have seen this. This bleeds repeatedly. Anyone? Yeah, pyogenic granuloma. So it's a very common acquired vascular tumor. Develops rapidly, days to weeks. Very friable, bleeds with very little manipulation, and can recur despite treatment. Usually surgical treatment is fine. Pulse dilator is fine. Curettage and cautery and shave removal. But in that curettage, cautery and shave, my experience is it's unfortunately there is higher rate of recurrence. So it's either surgical complete primary closure or Pdl Vascular Laser. So take home message: while many vascular lesions represent isolated finding, think outside the box, look at the whole child, refer accordingly. If you're worried, infantile hemangiomas grow early on. If they are in the midline, around the eyes, think about eye or ENT. And port wine stain, if it's in the middle line, which is the vascular blood supply, then do refer and think accordingly, because it can be Sturge-Weber syndrome. Now, this is this sort of common vascular lesions and in tabulated form. And let's talk about EB, epidermolysis bullosa. I'm not here to talk. It's a huge topic. It's a huge topic, and I'm not here to talk about all through the disclassification and treatments, new updates, and etc. I'm here to talk about ER presentation or first presentation. You are the first responder. You can see skin fragility. Now, I used to work at Great Ormond Street Children's Hospital. All my knowledge of EB is, I acknowledge and I say it's because of these fantastic people at Great Ormond Street, Professor Malario, Dr. Martinez, and EB team at Great Ormond Street and St. John's, who have done fantastic work in helping these families, young kids, and evolving and improving the frontiers of the knowledge in this disease. So I've taken a few photographs from Professor Malario's talk. A fantastic teacher, I have to say. So this is, think about this wall. This is skin, and all these bricks are cells. So you can see dermis and epidermis, and then the dermoepidermal junction. So this is where the EB can affect different parts of the skin. So in the dermoepidermal junction, we have hemidesmosomes, we have other sort of focal contact points, and then obviously in the epidermis, we have desmosomes. So obviously, once you think about the underlying pathophysiology and etiology of EB, it's complex. It's not easy. Well, I will say it's not for the faint-hearted. So don't worry. You don't need to learn all this thing because you are the first responders, ER, and you are just trying to help out the emergency management of a child with EB. The reason I presented that here is because so that you can think outside the box. It's multifactorial, and the EB patients, the young children, have chronic inflammation. So abnormal growth, abnormal or poor bone health, and pubertal delay. So it's not that they only present with the skin. They have, yes, the skin infection, skin fragility. It's the primary, but then think outside the box. Here in Pakistan setting, you might be the only doctor they are seeing. So do think, you might not have the whole team available. So that's the reason of this educational activity here. We have to help our patients. So nutritional deficiencies, if they are on the drugs, especially steroids, very often used here, think, are we harming the child or are we helping the child? Chronic inflammation, decreased food intake. They don't engage in feeding as the other kids do. Malabsorption, increased losses because of the skin, and increased energy requirement because the skin is always working. So steroids, exogenous steroids do inhibit osteoblasts, pubertal issues, malnutrition, so effect on the immune system, and sufficient fat, so which is lacking in this. So let me tell you about the whole picture of the EB, epidermolysis bullosa, where the skin is very fragile. It's a sort of a genetic skin condition, very common in Pakistan, unfortunately, because of the interfamily marriages, cousin marriages. So what happens with when you're thinking, when you're seeing a child, do think outside the box. You can see pain, itch, constipation, reflux, GU problems, cardiomyopathy, delayed puberty, and psychosocial. If the child presents to you with this sort of big blister, you have to pierce the blister with the sort of a sterile needle so that the roof can settle down. Don't leave the roof intact, so that the healing is more better. Petroleum jelly, Vaseline, impregnated gauzes. If there is not available, just put Vaseline on. Then be careful with the dressing of the child. Non-adherent dressing is ideal. And silicone dressing, even I'm having difficulty finding it here in Islamabad, so I don't know how easily available, but petroleum impregnated gauzes are available very widely, so please use those. Pain, so we talked about pain. So painkiller, paracetamol regularly regardless, but strong painkillers like opioid painkillers might be needed, especially around dressing change because it's painful, especially around bathing, that might be needed as well. Do consider age of the child. Please don't suggest aspirin because of Reye's syndrome association. And if you have to, go for stronger medications like amitriptyline or gabapentin. If any issues, please discuss with any other doctors who have experience in looking after these kids. Dental and nail care, so you are seeing in ER, if there are infection, or you have to educate them, dental and nail care, so that the families can have regular visits, or could be at least seen frequently, but at their local pace. Eye care, nutrition, so ophthalmology, think about that, and nutrition. So if you have a dietitian available, fine. Otherwise, there are high calorie nutrition is advisable. So talk about the diet with them, so they can think about it as well. क्योंकि वो आपको आके कहेंगे बच्चा वजन नहीं गेन कर रहा, जब गेन वजन नहीं कर रहा तो देयर आर नीड्स ऑफ द चाइल्ड, द बॉडी इज क्राइंग आउट के I need extra calories. Surgery, so mitten hands, so these are sort of fused fingers. बार बार स्किन उतरने से फाइब्रोसिस होती है, उसके साथ वो हाथ जो उंगलियां हैं वो स्टिक टुगेदर हो जाती हैं. You will need a hand surgeon, you will need an experienced plastic surgeon to deal with that. If you go in early, that's better. Otherwise, what will happen, they will lose their fingers for the rest of their life. Esophagus, reflux, issues with feeding, difficulty in feeding. So sometimes some types of EB, they will need regular esophageal dilatation, yearly or even more often if need to be. So think outside the box. Ask about the feeding sort of pattern. क्या उसको खाने में तकलीफ तो नहीं होती, क्या वो सॉलिड्स खा सकता है बच्चा, या सिर्फ लिक्विड पे गुजारा कर रहा है, क्योंकि सॉलिड दें तो वो बाहर आ जाता है, या उससे हजम नहीं होता, या वो अंदर नहीं जाता, या उसको तकलीफ होती है, then the esophageal dilatation is indicated. You need to refer them to the gastroenterologist. I do work with the gastroenterologist here who is who was trained and quite experienced from UK as well. So if you have any issues, we do have that services available here. Now I have to present Debra Pakistan. This is Debra UK and Debra Overseas, it's a charity, looks after the EB kids. And please do join them. इनके हाथ बने, इनकी help करें, and you will find that we are helping not only the kids, but we are helping the general community. Now, quickly going through the main manifestations of tuberous sclerosis, NF versus TS, neurofibromatosis versus tuberous sclerosis. I'm sure all of us know about this, so I will leave it here for a few seconds. The presentation will be available online on YouTube and Shifa International Hospitals Facebook page and my own Facebook page, as well as my website, dramjadkhan.com. So don't worry about that. You can again refer to these slides through that presentation. So skin manifestations of tuberous sclerosis, that's what we want to talk about, because if they present, twice I've seen patients, in fact 3 times, being treated for acne, or actually it was not. So we'll talk about that: hypomelanotic macules, angiofibromas, angle fibromas, collagenomas, which are shagreen patches, and then other minor diagnostic criteria for TSC. So hypomelanotic macules or ash leaf macules, these are the sort of ash leaves, and you can see this is very typical. And think about, so examine the whole child, when you're looking them, whether in your clinic or in ER. Nuchal skin tags, slightly late delayed onset. I've seen quite a few patients, actually, adults coming with the child for something else, and looking at this, I usually advise them about the they should be consulting themselves if they have other issues. And then cardiac rhabdomyoma, so heart. Think about heart when you are thinking of TS. Do think outside the box. Other organs involved in the body. Differential diagnosis, obviously people will hear in Pakistan, everybody walks and say, kya ye burst to nahi hai, vitiligo to nahi hai. It's something different, but if you know outside the box, this is the differentials. Look out or watch out for other skin issues. Nevus depigmentosis, it's again isolated, no other systemic involvement. Facial angiofibromas. So this is being treated for acne. These are not acne, these are facial angiofibromas. You have to look at acne, closed comedones, open comedones, inflammatory lesions, cysts, and then you will differentiate it between angiofibromas and those. And angiofibromas can be part of other genetic conditions, but once you pick it up, then you can explore other options as well, and very easily confused for acne. And facial angiofibromas obviously cause disfigurement, self-esteem. So twice I've seen young patients for self-esteem issues, but then picked out it's not acne, it's something else. And ungual fibromas or periangle fibromas. So you can see I've seen quite a few adults with this. Again, so it might be isolated incidental finding, but once you see this, see if the other skin issues or other systemic issues are present. Treatment, surgical or medical. Surgical, we know you can use pulse dye laser, carbon dioxide ablative laser, or excision, surgical excision. But there is medical option as well. So mTOR inhibitor like rapamycin, sirolimus, or everolimus. I've used personally sirolimus, fantastic outcome, along with the University of Bath patients and Bristol, Professor Finbar O'Callaghan at Great Ormond Street, and now Dr. Sam Amin and Professor Andrew Lux. Fantastic team. I used to work for neurology for Dr. Lux. He was my supervisor, and worked with Dr. O'Callaghan as well, while Dr. Amin was my colleague. And you see all these things, all new venues, new options, new treatments. And it's available in Pakistan. Bearing in mind, sirolimus ointment is available in Pakistan. People import it from Dubai, and it's not hugely expensive. It's, I think, around 1000 से 2000 रुपए की शायद ट्यूब है, कुछ इस तरह की कहानी है, दुबई से इंपोर्ट होती है. Please do help your patients. Some of them are affording, some of them are not, but give them the option. Informed consent. Now, conclusion, obviously, the oral rapamycin and sirolimus or mTOR inhibitors are available. Topical are as good as the oral ones. There are obviously further studies are happening as we speak. Surgical and medical options can be used in combination. With that, I will stop and I will say thank you very much. I've been a bit sort of faster today, just because we had so many slides, and we are on time. So thank you very much. Let me see if there are any questions I need to answer. Beta blocker dose and duration. So I've shared that with you. It's initially 1 milligram per kilogram, but then 2 milligram per kilogram per day in 3 divided doses. And usually treatment is around a year. When should we screen for intrahepatic hemangiomas? Yes, more than 5 lesions, more than 5 hemangiomas, do consider abdominal ultrasound. But abdominal ultrasound with Doppler will pick up the vascular lesion. If there is port wine stain, which should be done first, eye examination or MRI? MRI is difficult. हर जगह अवेलेबल नहीं है, हर बंदा अफोर्डिंग नहीं होगा, मगर आई एग्जामिनेशन तो हर जगह अवेलेबल है, आई डॉक्टर्स तो हर जगह हैं, तो पहले वो कर लें, फिर एमआरआई भी होती रहेगी, बट डोंट फॉरगेट अबाउट एमआरआई, दैट्स द मेन पॉइंट. The first 3 webinars, yes, they are available. Somebody from Malaysia have joined, and yes, they are available on Shifa International Hospitals Facebook page, or YouTube channel, Shifa International Hospital, or my website, dramjafran.com, as well as my Facebook page as well. Thank you very much. I think all the questions I have managed to answer. If you have any other further questions, don't worry. Feel free to join the next sessions, and you can write down the questions, and I will be more than happy to answer those for you. So our next session will be next Thursday, but because of Eid al-Adha, our last session will be on Saturday, next Saturday. So we will have 2 sessions next week. Both of them are on dermatological emergencies, and very, very pertinent and relevant to the frontline doctors, colleagues, including nurses, all medical staff in ER, clinics, or wherever you are when you see the patient first line. So please do tell your other colleagues to join in as well. Again, it's a free educational activity just to increase awareness about dermatology, pediatric dermatology in more focus, and to answer your questions if you have any about dermatological emergencies, inshallah, next week. So thank you very much and have a lovely day.